UITM. The webinar this morning is titled Tissue Biomarkers in Atherosclerosis and Obesity, Significance and Application, which will be delivered by Professor Dr. Effat binti Omar. Allow me to introduce our speaker. Dr. Effat Omar is a professor in pathology, a consultant histopathologist, and is currently the Deputy Dean of Academic and Student Affairs at the Faculty of Medicine, UITM. She is also an Associate Fellow at the Institute for Pathology, Laboratory, and Forensic Medicine. I perform a COE in UITM. She graduated from the Royal College of Surgeons, Ireland, did her postgraduate degree at University Science Malaysia, and subsequently worked there for a number of years before moving to UITM. She is currently involved in over 10 research projects in her capacity as a histopathologist with expertise in immunohistochemistry, especially on investigative and novel markers. She has also published more than 70 articles, both in index and non-index publications, as well as monographs and book chapters in various pathology-related topics. She has also received many innovation prizes and a few copyrights to her name. We will open for questions at the end of this session. Professor Dr. Effat, the floor is yours.
Assalamualaikum and very good morning, everyone. Thank you, Associate Prof. Datin Dr. Mansyarah for the kind introduction. Thank you to the audience for coming to this session, and thank you to the Research Office for having this webinar. I think this is a wonderful platform for all of us to share our research and inform each other of what we are doing. So let me share my PowerPoint presentation for today. Okay, is it okay if I put it in this form instead of a slideshow? Because if I put a slideshow, it seems that I cannot see the Google Meet platform here, which I would like to see in case there is comments or question from all of you. So let me start, okay? So apologies along the way if there is any glitch or anything during my presentation. So before I move forward to tell you regarding the research on atherosclerosis and obesity that I've done, let me first introduce to you what is it that I will be covering during this talk. So at first, I would introduce to you what is my discipline, which is histopathology, or in other names include anatomic or surgical pathology. And then I'll go through a little bit on the disease, atherosclerosis, as I can see that the audience is diverse here. So therefore, I think I talk a little bit on this disease, and then we'll go through the research regarding the tissue biomarkers and the significance and the application. This picture is taken in 2016. These are the histopathologists that is working on cases, to diagnose cases. This is in Turkey. This is in Trakya University. I went here on a Mevlana exchange program, which I totally recommend to all of you. Unfortunately, it has been cancelled for 2020. Basically, 2020 has been cancelled. So therefore, nobody can go to this exchange program this year. But once it is okay again, I totally recommend all of you to go there. It is a very eye-opening experience to learn from our colleagues elsewhere. So they are this lady here. She is a histopathologist, and this is her student, and they are seeing slides together. Okay, a little bit of introduction to the discipline. Histopathology is a discipline whereby we diagnose conditions or diseases based on study of tissue. this person, Karl Rokitansky, if you are in medicine, you see Rokitansky and you see Workhouse, you recognize them from the various names of diseases or clinical conditions that we name based on them. So Rokitansky is a pathologist, but he doesn't believe in microscopy. What he do is he observe diseases through autopsies. So he did a lot of autopsies. In the literature, it was said that he did around 300,000 autopsies in his career. So he observed disease based on looking at the tissue with his naked eye. Subsequently, this person, Virchow, he uses a microscope. At his time, the microscope was already invented and it was already being made into an instrument that is good and were able to see the cells. So he observed cells and he correlated the gross disease, the disease changes with the cellular changes. So he was the father of modern pathology, so to speak. And his journal, which is called Workhouse Archive, which originated at the turn of the 20th century, is still being printed now and is one of the higher index journal for pathology. So if you are able to publish in his journal, you're considered to be a very impactful person in pathology. So that's Virchow. But unfortunately, sometime in the early 20th century, there is an incident whereby there's an emperor. This is a story of it. There's an emperor in Prussia, and he has a lesion in his vocal cord. And at that time, there is a surgeon who take a bit of tissue from the mass and ask Virchow to see under the microscope. And unfortunately, that time Virchow diagnosed the condition to be benign. But subsequently, the lesion grew and the emperor died. And later, somebody saw the slide and they say, okay, this is cancer. And at that time, the confidence was lost regarding whether somebody can really diagnose a disease by looking at the microscope, by looking at the tissue under the microscope, because the changes are not well defined. So the practice of histopathology goes into a decline from that moment until it was taken up by American institutions. During the early days, the surgeons are the one who look at the tissue. So the surgeon, they did surgery and then they take the tissue and do processing and staining and all, and then they look under the microscope. So this is them looking under the microscope, and they are the one who form the basis of the modern practice of histopathology. So histopathology is only separated from the surgical practice in 1960 to become its own discipline. So only in 1960. So it's very recent that it becomes its own discipline. And as a practicing pathologist for over 16 years now, I can say that it takes a long time for a person to learn regarding the normal variation of tissue changes. Okay, what I mean is that histopathology training, if you want to be a histopathologist, you train after the basic medical degree, you train for 4 years. After these 4 years, you were able to diagnose the sorry. You were able to diagnose the gross, that means the absolutely abnormal tissue. So you'll be able to diagnose what is grossly. When we say grossly, it means when you see with the naked eye, this is normal and this is abnormal. I think everybody can see that. If there is a normal liver, for example, and you see a liver with a tumor, you can definitely say, okay, this liver is abnormal. So basically, if you take a section from this abnormal liver, you can say, okay, this is definitely abnormal on histology. So after 4 years, you'll be able to do that. But if you have normal and there is a spectrum before it becomes definitely obviously abnormal. So the spectrum before this takes a long time for somebody to be able to learn on. So this is what I found with this years of practice, is just to diagnose between this normal and the spectrum, the subtle spectrum, to become abnormal. It takes a long time for us to understand the disease and understand the disease process and how it translates into what appears under the microscope. So that is what I do. And if you think about research process is not a normal, research process is not what you see in the normal disease process. It is like you induce the disease in an animal, for example. So when you induce the disease in an animal, it is an artificial situation. So therefore, the changes are even more different compared to the one that you see in the human being in the histopathological practice. So that also takes some time for you to be able to be accurate in your description or in your finding in research process. So that is the basis also of this talk today. Okay, so that is regarding the discipline. So in the modern day practice of histopathology, this is what is happening right now. Is basically you interpret the morphological changes that you see in the tissue and turn it into a relevant clinical information, so that you can tell whether there is a presence or absence of disease. If a disease process is something like, for example, in this picture here, this is from a stomach, and that's a gastric ulcer there. So if you take a tissue from this area, for example, of the stomach, and you see under the microscope, you can see how the disease process changes, because it's a long process whereby you get healing, and then you get injury again, and then you get healing, and the absence of disease doesn't equate the absence of histological changes. So sometimes there is discrepancy there. And it is important for everybody involved in the care of the patient to recognize that this is what it is. And also the histological information is also used to prognosticate. So for example, if a patient have hepatitis, for example, they do biopsy of the liver, and the histopathologist would then tell what is the disease process that is occurring in the patient and what will happen. So for example, if there is a lot of active inflammation, that means a lot of inflammatory, acute inflammatory cells, the patient would most probably be very sick during that time. And what will happen to this patient, or if it is more chronic, what will happen to this patient. So therefore this information can be conveyed to the patient, and they would know what is expected to happen to them due to the disease. And also for the clinician, it would indicate what management that they would do to this patient. So if there is acute inflammation, they would do this management, or if there is no acute inflammation, they would do the other management. So it allows for treatment to be instituted to the patient. Sometimes you do intraoperative diagnosis. So in this instance, for example, there is surgery, and the surgeon wants to know whether the tumor, if a patient have tumor, whether the tumor is benign or malignant. Because if it is benign, then they will resect only a small area. But if this malignant, they may resect a larger area, for example. So there is also intraoperative diagnosis, where the surgeon would send a bit of the tumor tissue to the histopathology lab, and we will do frozen section and give a diagnosis of whether it is benign or malignant, so that they can manage accordingly. Cytology is another branch of histopathology, whereby instead of tissue, we see cells, and from the changes in the cells, we can diagnose whether the patient have disease or the patient does not have disease. So cytology is used as a screening tool, but some areas of cytology has been developed so much that it is also used as a diagnostic test rather than just a screening test. So this is how histopathology is used in modern medical practice, just to give you a background on the discipline itself. Okay, so now we go towards the disease itself, or atherosclerosis. Okay, this is the main bulk of my research in I-Perform. As you know, I-Perform is a special niche is cardiovascular disease. One of the niche areas is cardiovascular disease. So I'm involved in this as well. Atherosclerosis, as you know, is disease of medium-sized and large arteries. So in this situation, you have accumulation of macrophages that is laden with fat inside the inner layer of the artery. So the artery have 3 layers. I'll show you here in this picture here. So this inner layer is called the intima, and the middle layer is called the media, and the outer layer is called the serosa. The intima is usually very thin.
Blood protection index, yeah. This one is numerical burden prediction, disaster risk reduction.
And then the middle layer is the media, and it contains smooth muscle layer. There's a smooth muscle layer surrounding the intima, and then the outer part is just a serosa, which is the covering of the outer covering of the artery. So in this condition, the endothelium is dysfunctional because of injury. For example, if somebody is smoking or there is increase in lipid, especially oxidized LDL, it will cause injury to the endothelium, and it is permeable to macrophages, and the macrophages engulf lipid that is also going into the intima, and they accumulate inside the inner layer of the blood vessels here, and thus the inner layer of the blood vessel become thickened, as in this artery here. So this artery, it should be well rounded, but this area is broken because if you have a diseased artery and you try to cut it, usually there is a little bit of cracking inside the tissue, and therefore you get this kind of, we call it artifact. This is an artificial break. This is not a real break from the disease. This is artificial because of the processing and the cutting and all. So it's supposed to be all around here. So you can see that the intima is thickened a little bit here, but the inside here, which is the lumen of the artery, is still very, very large. So therefore, if a person is, this artery is in somebody, the blood flow is still not impaired. So the patient would not have any symptoms because of the disease. Compared to this blood vessel, okay, you can see that the picture has a little bit of abnormal shape. This is because this artery is actually quite big here. So we've taken 3 pictures and put them together because it doesn't fit in one microscopy frame. So this is a composite picture of one artery, and you can see the thickening of the intima, or the inner layer, is much more in this artery, and the lumen is more narrowed compared to this one. So this is an established atherosclerotic lesion, and you can see the lumen is only 50% of what it should be. And for somebody who has this type of changes in their artery, the blood flow is like 50% reduced. So if they have strenuous physical activity, for example, if they go jogging, for example, they will get less blood flow and more demand of oxygen from the exercise or actively contracting myocardium, and therefore the patient will present with chest pain. So it is called angina. So in angina, this is what the artery look like. In this third picture here, you can see the lumen is greatly narrowed. More than 75% is obstructed, and only perhaps 25 to 30% that is patent here. So this patient here, obviously the patient has died. That's why the artery is here in our section. But this patient here, the activity that he or she would be able to do is much less compared to the one with this artery here at the top. Okay, so at some point, this endothelium, the inner lining of the blood vessel can be injured further, and you can get formation of thrombosis inside the lumen here. Then you can get complete obstruction of the lumen, and therefore this is when the person will have a heart attack or myocardial infarction. So when there is myocardial infarction, there will be sudden closure of blood flow to the distant part of the heart or the blood supply, and this leads to death of the heart muscles at the further part where the blockage. So when that happens, there will be extreme pain in the chest, and unfortunately around 30% of this patient, they will have sudden death because of this. Okay, so this is atherosclerosis as we see on tissue sections. Okay. So what are histological biomarkers? So these biomarkers, are they real? Can they be used as an investigative tool? What are they actually? So histological biomarkers are accepted biomarkers. This is a definition that is given by, believe it or not, there is a biomarker definitions working group. This is part of an FDA group where they evaluate research in drug development, and they define biomarkers as parameters or characteristic that you define in a tissue or a protein that can be objectively measured. So for example, here there is a histological section that contains cells here. So a parameter here can be the number of cells. So the number of cells can be objectively measured, and therefore it can be a marker to measure the normal biologic process, the pathologic process, or respond to therapeutic intervention. So this is what we mean when we say histological biomarkers. So it can be the number of cells, it can be the shape of the nucleus, as long as it can be measured. But of course, sometimes the things that you can see are not enough to measure some changes. So sometimes you need something that you cannot see. So then comes the other methods of detecting histological changes that is not visible by the naked eye. So we call that some tissue biomarker studies. So these are example of tissue biomarker studies. Immunohistochemistry is one, immunofluorescence, in situ hybridization. These are changes that occurs in the cells that you want to detect, but it is not changes that you can see directly with the naked eye. So you can detect that by using immunohistochemistry. So the characteristic of this immunohistochemistry is as per what is acceptable as a biomarker. That is, there is a defined protein or a defined parameter that you want to measure, and it can be objectively measured, and it can be an indicator of the response to therapeutic intervention. So therefore, these methods are acceptable methods for you, for us to use when we want to measure histological changes in the tissue. Of course, histological changes are in the tissue. So this is an example of what you get if you use these methods to measure the changes in the tissue. This is immunofluorescence here. Immunofluorescence. If there is a positive immunofluorescence, you will get this apple green staining here. This is because the fluorescent dye is hit by ultraviolet light and they give out the green color. So if there is this green color, is an indication that the test is positive. This is immunofluorescence that is used on cells. This is on tissue. This is on cells, and you can have the immunofluorescence to detect, for example, the components of the cytoplasm or the components of the nucleus. And if you use a different detection fluorescence, you can do multiple markers in a single slide, and therefore you can observe the beautiful color changes of the various areas of the cell that is picking up the stain, the fluorescent stain. This is FISH. I'm sure you're also familiar with this method. FISH is used to localize genes in chromosomes. Okay, so FISH is used a lot in studies of cancers and diseases where you want to detect what are the genetic changes that occur in the chromosome. And this last bit is immunohistochemistry staining, and the immunohistochemistry staining shows here the brown color, brown area is the positive test and the blue area is a negative test. The advantage of immunohistochemistry compared to the other methods is that you don't have to use a UV microscope. Light microscope is enough. So if your lab doesn't have UV microscope, immunohistochemistry is okay, you can use it. The other advantage is that the fluorescent dye fades after a few hours, and you may still get a fluorescent if you see the slide the next day after 24 hours, but after a few days the staining fades away almost to nothing. So it's very difficult if you want to go back to the slides and confirm that there is positivity or there's not positivity after a few days. The stain will fade away. Compared to immunohistochemistry, the stains will remain there in the tissue section as long as you do it properly for many years. So if, let's say, you have doubt regarding your results and you need to go back and check on the stains, you can still do that even after a few years, and it will still be as it was in the first time that you see it. So it doesn't, it's not really affected. So that is why a lot of researchers use immunohistochemistry rather than the fluorescent study because of that. So these are the methods that is available to detect tissue biomarkers. Okay, the principle of immunohistochemistry, sometimes when I have students and if they don't understand these principles of immunohistochemistry, it becomes very difficult for them to understand the process of doing the test as well as the interpretation of the test. So basically there is the antigen in the tissue here, and the primary antibody is raised against the antigen. So primary antibodies are raised in an animal. So the animal is injected by the antigen and they have antibodies against the antigen, and these antibodies are purified from the animal and they become the primary antibody that can detect the antigen. So this is a primary antibody. Okay, so primary antibody detects the antigen of interest. So if you're interested in CRP, for example, you buy primary antibody for CRP. If you are interested in P53, you buy primary antibody for P53. The primary antibody is the most expensive part of doing immunohistochemistry. And then this is indirect detection. So in indirect detection, you have a secondary antibody that detects the primary antibody. So this secondary antibody binds to the non-antigen binding site of the primary antibody and stay there, and at the end of this antibody there is attached usually a label. So this is like a fluorescing dye, for example, or it can be like in immunohistochemistry, instead of a dye it is an enzyme. So for example, alkaline phosphatase, and subsequently you give the substrate to the enzyme, and the enzyme acts on the substrate and you have the color change. So therefore, if there is binding to the antigen, there will be color change. So the color change is indicative of a presence of antigen in the tissue. So that is the principle of immunohistochemistry. So therefore, if you see the previous slide, all of these positive cells, the brown cells, these are the cells where you have the substrate being activated on these cells. There is already, the enzyme is already bound to the antigen, which is bound to the cells, and the substrate has become activated on this cell. So therefore, you have the precipitation of the substrate at the specific site of the tissue. So that's another advantage of immunohistochemistry, whereby you can see where the antigen is expressed on which cells. So either is the tumor cells, or not the tumor cells, or the other types of cells. So this gives you an extra added information for you to interpret the test. Okay, so that is the principle of immunohistochemistry. Okay, so now how do we apply this principle, or how do we apply this immunohistochemistry into our study? Ever since I joined UITM in 2007, I would like to thank Prof. Hafiza, because she was the one who invited me to join her atherosclerosis study to do the tissue part of her study. At that time, she doesn't have anyone to do it. So I would like to thank Prof. Hafiza very much for the opportunity. And I've been doing this study for the last 10 years since I've joined UITM. And this is the result of this part of the study. Subsequently, I've been involved in other studies as well, but this is, I'm just presenting here the atherosclerosis studies. So our first study is this study. This is a tissue section from part of the atherosclerosis. So you can see the blood vessel just now. So I just take a higher power view of the surface of the atherosclerotic lesion. And this is the brown positivity of A. Here is ICAM. So that's the ICAM detection on the surface of atherosclerosis. This endothelial positivity here for ICAM. And if there is no brown here, it is negative. So obviously, as I told you, in experimental study, things don't always go as you would like it to go. And this tissue is supposed to be blue, but here is brown because of some staining background or something like that. So sometimes you have to contend with this type of what they call insufficiencies when you do studies, because students are not experts in doing histochemistry, not like the lab, and therefore you have to take that with a pinch of salt, that if there is no staining at the area of interest, therefore it's taken as negative. So again, this is the endothelial staining for NF-kappa B, and this is negative staining, and so on and so forth for the various markers that we have here. So just the background of this study. In this study, we use tocotrienol-rich fraction, which is palm-derived tocotrienol fraction. As you know, palm oil has naturally has high tocotrienol content. So we obtained an enriched tocotrienol substance from Sime-Darby, the oil or test treatment substance from Sime-Darby, and apply to high cholesterol diet induced atherosclerosis in rabbits, and see whether there is any difference to the formation of atherosclerosis or regression, or any difference at all. So in this study, we found that in terms of the soluble markers, that means the markers in the blood, there is no significant difference for the inflammatory markers, which we measure CRP and interleukin, as well as the what do you call that, oxidative stress markers are also no difference between the treatment group and the control group. But what we found was different was the expression of tissues inflammatory marker. The atherosclerotic inflammatory markers are reduced in some of the group. So for example here, we wanted to know what are the dose of tocotrienol enriched mixed fraction that is most effective in reducing the endothelial inflammation. And we found that 15 milligrams per kilogram has a least amount of ICAM1. ICAM1 is the adhesion molecule that we saw before, and this is reduced in the tissues, the endothelium of the rabbits. As well as here, there is reduction in IL-6 in this group. But subsequently, there is we correlate all the data, and the best concentration for TRF in this study was 15 milligram per kilogram. So that was what we found. So from this study, we learned that the soluble markers, that means markers that is present in the blood, is not always the best indicator of an effect of a treatment, and tissue markers may be more important compared to the soluble markers. And this is also important because we want the effect in the tissues, and the tissue effect does not always translate to the blood. So therefore, if you just measure the blood, you may miss the effect that you have in the tissues. Okay, so from this experiment then we move further to the next experiment. So this experiment, we decided to use two groups. One is we call that early atherosclerosis, and the other one is established atherosclerosis. The question is whether which one is more affected by the treatment with TMF. We're still using a tocotrienol mixed fraction at that time. Is it the early part of atherosclerosis formation or the late part of when the atherosclerosis is established? And we also ask the question of what if the TMF is given before the insult or before the formation of atherosclerosis, and what if it is given after the atherosclerosis has been established? So that was the questions that was asked for this study group. And here on this side is the early atherosclerosis group, and this is the late atherosclerosis group. This is Sudan 4 staining. Sudan 4 is a stain that we can use on tissues. It binds to fat. So atherosclerosis have a lot of fat inside them. So when we treat with Sudan 4, there is a red discoloration at the area of atherosclerosis. And I'm not sure if you can see it very clearly here, but here in the placebo group of the established atherosclerosis, there is a lot of this red area in the aorta, this aorta of the rabbit, compared to the TAMF treatment. And when we do analysis in terms of the area of atherosclerosis formation over the entire aorta surface and make it a ratio, we found that in both early and late atherosclerosis, there is a reduction in atherosclerosis area in the treatment group, the TAMF treatment group, compared to the placebo group. So that was the first positive finding that we found in this study. And subsequently, we moved to obviously in both groups you have established atherosclerosis and early atherosclerosis. So we look at the immunohistochemical expression of the various markers here. So from inflammatory markers, adhesion molecule as well, NF-kappa-B, the back mechanistic control for the inflammation, as well as here SMA is smooth muscle actin. In atherosclerosis, there is proliferation of the smooth muscle, the medial smooth muscle, and they migrate into the intima here. So we look at smooth muscle actin, as well as MMP9. MMP is methyl metalloproteinase, is an enzyme. So this enzyme has been found to be increased as the atherosclerosis progress. So MMP9 is released by inflammatory cells, and they digest the wall of the blood vessels and make the atherosclerosis more established. So we look at MMP12, one of the subunit of a type of MMP that is present, that is found to be present in atherosclerosis. And so this is what we found from our study. We found that the prevention model, okay, just talking about the immunohistochemistry here, in the prevention model is that we give tocotrienol enriched mixed fraction before we give the high cholesterol diet, and it is sustained during the high cholesterol diet as well. So in this model, we see a reduction of inflammatory markers in the treatment group compared to the placebo group. So there is a lot more changes in the inflammatory markers in the tissue compared to in the placebo group. And these changes is not really found in when we measure the CRP in the blood or the IL-6 in the blood. The changes is not significant. It's comparable between the two groups in the blood, but it is significant in the tissue in the prevention model. In the treatment model is when we give high cholesterol diet first, so they have atherosclerosis formation, and after that we give tocotrienol. In here, the changes is not really as dramatic, whereby we have only one significantly decreased marker, which is CRP, but the rest is really not really significant. So the finding here suggests that we interpret it as if the tocotrienol enriched mixed fraction is given earlier compared to the disease, it has a more significant effect compared to if the disease is already there, then you treat with tocotrienol mixed fraction. And this result that we found when we correlate with the other findings in human study as well, they fail to show a good response with tocotrienol or vitamin E treatment in patients with atherosclerosis. So that is perhaps
Salam, Prof.
Yes.
Can you please make it in slide view because it's a bit small from our
screen. Okay. Sorry about that. Okay. So,
thank you, Prof.
Okay. Okay. If I make this slide view, is it okay for you now? You can see it bigger?
Yes, much better.
Okay, thank you. But I cannot see you, so I cannot see any comments or anything like that. Okay, but anyway, you just shout if you have any question, okay? So the interpretation or the significance of this study is as I said before, the prevention works better for tocotrienol intervention compared to the treatment model. So this is the application or the finding that we have from this study. So those are the two atherosclerosis studies that was performed, that I was involved in, and that is the findings and the application that we found with this study. Okay, so the next one is obesity study. So I've been involved with only one of this obesity study, and to me this is interesting because this study is not done in animals, but is done in human subjects. So in this study, the subjects are post-mortem deceased patients, post-mortem subjects, and they are divided into whether they are obese or they are lean. And this is defined as having waist circumference of more than 80 centimeter or 90 centimeter. Is centrally obese subjects compared to lean subjects. Okay, so there are 35 of the obese subject and 37 of the lean subjects, and from the tissue, we did immunohistochemistry to detect this marker CRP, IL-6, PI1, TPA. The rationale of doing this study is we know that for people who are obese, they are more at risk to get cardiovascular disease, also more at risk to get diabetes as well as hyperlipidemia. The hyperlipidemia is the one that is leading to formation of atherosclerosis and therefore cardiovascular disease. So by conjecture, if there is obesity, there is higher risk of cardiovascular disease. So the question is, what is the link between the obesity and the formation of cardiovascular disease? And also we know that in obesity, there is higher levels of inflammatory markers as well as the oxidative stress markers in obese compared to the lean control. So why is there more of this as observed? So therefore we go to the tissues and we try to find out what is happening in terms of the expressions of these inflammatory markers. CRP and IL-6 are inflammatory markers. PI1 and TPA is a pro-thrombogenic markers. This has also been shown to be increased in patients with cardiovascular disease. Resistin and visfatin are adipokines. They are hormones that is released by the adipocytes, and they are also a paracrine. They have a paracrine effect for the adjacent adipose tissue as well. So the study is evaluated using a semi-qualitative methods, and results are the results are analyzed by putting them into boxes, chi-square test. Okay, so this is what we found when we do the study. Again, the good thing about immunohistochemistry is that you can see where the protein localizes. So this is a negative stain and this is a positive stain for CRP. And you can see that there are good brown stain around the adipocytes. Adipocytes are rounded structure like this, if you see under the microscope, like here, rounded structures, but the area in the middle of the cells, they are fat. The cytoplasm of the cells are just a rim outside the fat there, the fat area here. And this is what that is taken up the CRP stain. So it tells us that the CRP is within the cytoplasm of these adipocytes. This is a control tissue, just to show you what it looks like in the liver. So this is liver tissue, and this is the CRP within the liver. It is in the cytoplasm of the liver. And this is for interleukin 6, and the control tissue is lymphoid tissue. And you can see that it is also localized within the cytoplasm of the lymphoid tissue, the interleukin 6. And when we do staining of the adipocytes, the expression is not that much. So it's just a very low expression, but you can see that it's localizing also at the cytoplasm of the adipocyte. So that's interleukin and CRP. Okay, so what we found is that VAT is visceral adipose tissue. The expression in obese and lean here, there is a higher expression of CRP in the visceral adipose tissue of the obese compared to lean, and this is a significant amount of difference between these two groups. Okay, that's the CRP. And when we see both CRP and IL-6 in the group, in the obese patients, the obese subjects, if we see compare between the visceral and the subcutaneous adipose tissue, CRP in this, we can see that the visceral adipose tissue has a lot more CRP, higher score of CRP compared to the subcutaneous adipose tissue. And if we look at the lean group, Also, the VAT is significantly more expressing of CRP compared to the subcutaneous adipose tissue, and also the interleukin-6 is also more expressed in the visceral adipose tissue compared to the subcutaneous adipose tissue. So this results somewhat supports the previous research that reports visceral adipose tissue is associated with higher cardiovascular disease compared to subcutaneous adipose tissue, and also it supports that the subcutaneous adipose tissue is the good adipose tissue compared to the visceral adipose tissue in the expression of this inflammatory marker. PI1, okay, PI1 prothrombogenic marker. Okay, this is what PI1 look like. You can see that also expressing in the cytoplasm of this control tissue. This is again the liver, so it is present nicely in the cytoplasm. How you know that this stain is working is because the localization of the antigen is specifically where it's meant to be. So if it is localized everywhere, you know that that's not the real stain, is a false staining. So if it is localizing like this, a nice and clean background, you know that this is working and it is detecting what it's supposed to detect. And this is PI1 in adipose tissue. Again, you can see the nice clean staining of the cytoplasm, and is a specific staining. So therefore, this is a good staining that we had from PI1. And again, we observed that in the obese group, the VAT is more highly expressing of PI1 compared to the SAT group. Okay, visfatin, we go to the adipokines now. Visfatin is highly expressed by the fat tissue. It's no surprise because it has been postulated that this fat tissue produce the hormone, and this is a control. Okay, again, liver tissue control, and we have shown that by immunohistochemistry, you can demonstrate that the adipose tissue does have a visfatin within its cytoplasm, and the obese subjects have more expression of these adipokines compared to the lean subjects. And resistin as well. Okay, this is a resistin stain. Unless if you know that is what antibody you use, so it's very important that you label on the slide what antibody that you use for that particular slide, because it's all brown and blue, and it's impossible to tell what type of stain if you don't label it, so you get lost. So here is resistin, again in the liver. We use liver as control, and you can see the good staining in the liver cytoplasm here, and also a good uptake in the cytoplasm of adipocytes. So we also found here that in the VAT in obese and lean group, the visceral adipose tissue is highly expressing of resistin in both in the obese compared to the lean group, and also in the subcutaneous adipose tissue, it is highly expressing in the obese group. So perhaps the subcutaneous adipose tissue is also expressing or producing more resistin in the obese group compared to the lean group in this study. Okay. More on resistin. This is comparing between the visceral adipose tissue and subcutaneous adipose tissue in obese group, and you can see the subcutaneous have a lot more expression of resistin compared to the subcutaneous one. And when we look at the same in the lean group, also we find more expression in the visceral compared to the subcutaneous adipose tissue. So about this, the interpretation or the significance or the application of the results that we found here, it's in agreement with the observed clinical observation that in obesity you have more inflammatory markers in the bloodstream. Unfortunately, in this study, we did not do inflammatory markers in the blood. We do not take blood. We only see the tissue. But the novelty in this study is that we show that in adipose tissue, using immunohistochemistry, you can demonstrate the presence of a lot more of the inflammatory markers and proto-homogenic marker, as well as more expression of this adipose resistin and adiponectin, resistin and bisphatin, which is adipokines, within the visceral adipose tissue, especially in the obese group compared to the lean group. Now, the question that arises from this study is that whether the adipokines are produced by the adipose tissue, or whether the increase in these markers systemically in this obese patient is the one that is percolating or going into the adipose tissue rather than the other way around. So that is the next question to ask from this observation, from the result of this study. Okay, so from the work that we did with atherosclerosis, Alhamdulillah, we went on to get a lot of awards and also copyrights from this work, and this is a good thing that we got from the studies for the last 10 years. And also there are postgraduate students, and these are the postgraduate students that are really did the job. So I thank them very much, and they are part of our family in iPerform. All of them have graduated except for Amira. Amira is doing a new study that we have now. And of course, I would like to express my appreciation to all my co-researchers, Prof. Iza, Associate Prof. Datin Dr. Mancharan, who is the kind chairperson of this session. Dr. Nurul Ain was our postdoc before, and of course Associate Prof. Dr. Suhaila, which is my counterpart when doing the blood, the soluble markers rather to my tissue markers. So that is the end of the talk. The thing about doing research is that although you are happy to be able to contribute something to the knowledge that is the current body of knowledge, but it always humbles you in terms of when you find something, it leads to having more questions rather than just answering one question. It leads to even more questions. So you know that you are how much that you actually know from doing research. So this is something that is I think is very humbling when you do research, that you just know how much that you don't know, and there's always something else to be done for you to explore or produce more knowledge, or get more explanation from your observations, and so on and so forth. Okay, so that's it. Thank you for your attention.
Thank you, Prof. Effat, for that in-depth talk about atherosclerosis. It's, I think, it is sharp 11. So we probably can take one or two burning questions if there is any. Otherwise, if if you would like to leave your email in the chat group, and if anyone has questions, they probably can put it into the, could probably email you directly.
Yeah.
I don't think there are any questions in the chat group that I have noticed.
There's one, Sharon. Sharon,
Okay.
there's one.
All
Yeah,
right.
here there is a comment from Iman Nabila.
Okay.
Okay, are there any specific condition or specific types of tissue that we need to use IF and IHC? For example, can I do IF to check for atherosclerosis biomarkers? Okay. IF, if you want to use immunofluorescence, the current kit for IF needs you to use fresh tissues. So for example, if you have fresh atherosclerosis tissue, then you can use immunofluorescence. If you have fixed tissue and you have embedded into a paraffin fixed block, then you do immunohistochemistry. Okay, that's another disadvantage of IF, that you have to use fresh tissue. So fresh tissue, as you know, is very difficult to handle, and you have to use a frozen section machine. Which is available in the lab. So you can use that frozen section machine, and from there you do IF. But that's the thing about IF. Okay, could you share your opinion on translating your biomarkers into biosensors? Okay, that's a very good question. In fact, one of the things that I set out to do after my postgraduate, when you are in academic institution, you want to make a difference not only by teaching but also by producing, for example, diagnostic kits, so that the patients can be better diagnosed, especially if you are working in the lab, like I am, being a diagnostician, and you know that there are things that you cannot see. So one of the things that I wanted to do is to have a better diagnostic tool to diagnose, for example, thyroid cancer, for example, right? So if you have thyroid cancer, if you have a section of tissue and you don't know whether that tissue, just like Workhouse, the story of Workhouse many years ago, you don't know whether this is benign or malignant, you would like to have a diagnostic biomarkers that can tell you, okay, this is malignant, without you having to see that it's malignant. So therefore, that's one of the things that I want to do. So whether you can turn the biomarkers into biosensors, yes, you can, but you need a whole lot of sample size for you to have, a good, what do you call that, measure of the disease. And this is a difficult part for us, to get a good sample size and human samples rather than experimental. Because if you do the experiments and you say, okay, this is significant, and the next thing when you apply it to humans, it doesn't work. So in the end, you need human samples, and this is what we don't really have in our setting. Yes, thank you for the question. Okay, I think that's it. No more question. Dr. Sharon.
All right. In that case, thank you, Prof. Effat, and thank you to the Office of the Deputy Vice Chancellor, Research and Innovation for organizing this talk. I'm sure it was useful to everyone, as it was to me too. So with that, I thank you everyone again for your participation. Thank you.
Thank you, everyone. Assalamualaikum.